I'm Dr. Jochelson. I'm the Director of Radiology at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center. I'm a professor of radiology here, and I do primarily breast imaging with a little bit of PET-CT. Thank you for that question. It's a very good question when it comes to breast cancer. So plain films are great if you see something, but they are not very sensitive. So while if you have a patient who has new localized pain in one bone, it is a good idea to start with a plain film. If it's negative, that doesn't rule out the possibility of bone metastases. Up till several years ago, I think many people thought bone scans were the best way to look for bone metastases, and these were either sulfur colloid or sodium chloride bone scans, and these are very sensitive. The problem is that they're not specific. The study that I believe is the best study to start with in a patient where you are suspecting metastatic disease is PET-CT. And I'm going to show you just briefly, a little data looking at the sensitivity of PET-CT when compared to CT plus bone scans. And there are multiple papers on this topic, but since we have limited time, I think this one really addresses the question that you've asked. And this took 91 patients who had breast cancer and compared PET-CT to CT plus bone scan. In about 70% of the patients, PET-CT and CT or bone scan agreed. However, in 30% of the patients, PET-CT demonstrated more disease than CT and bone scan. Now, this is not always important. Here is a woman whose bone scan does indeed show multiple bone metastases. But as you can see on the PET scan on this same patient, there are many more bone metastases than you can see on the bone scan. And this may or may not be important. We do know that breast cancer can be heterogeneous, and therefore some of the metastases as you look forward may get better, some may get worse in the same patient. So it is important to get a good idea of the extent of disease. But I think this is the perfect situation where there is only one bone metastasis. This happens to be a friend of one of my bosses, and she presented with some vague symptoms, but really nothing was seen on the bone scan. Nothing was seen on the CAT scan. The only place that we saw an abnormality was a single enhancing bone metastasis at L4. So this is where PET-CT shines. The other thing that PET has that is superior to bone scans, it is more specific. Bone scans can be positive in patients who have metastatic disease, but also in patients who have fractures, infections, and arthritis. And therefore, it may be that you see a positive bone scan, but you're not sure what is going on. This is a study that we did comparing the specificity of PET-CT to that of bone scan. And we had about 100 patients in the 163 women in this study. And in many of them, there were concordant findings between the PET-CT and bone scan. But there was a population in whom the two studies disagreed. So 100 were concordant, 31 were discordant, and then we had biopsies in about 12 of them. And in every single one of the patients where there was a discordance and a biopsy, PET-CT was correct and bone scan was not. A more sensitive way of looking for metastases, but certainly a slightly more difficult way, is to do an MRI or a PET MRI. The reason MRI is even better than CT is that most metastases begin in the bone marrow and then go into the cortex of the bone. CT looks at the cortex, bone scan looks at the cortex. FDG may look at the marrow alone, but the resolution is not that good, whereas MRI you can look at the bone marrow and actually don't see the cortex of the bone as well. So this is one of the earlier studies, 109 women retrospective study. 25 of these women had bone metastases, and you can see that while PET-CT did find 88%, MRI PET found all of the bone metastases. And then looking per lesion, again, MRI did find more metastatic disease. Here is an example of a patient in whom the PET, the FDG, is not taken up at all. But on the MRI, you can see replacement of the bone marrow. And this has been found in other malignancies as well, and particularly multiple myeloma. Now, not all histologies are equal. And what we have learned is that patients with invasive lobular cancer, who we also know we often miss the breast cancers because they grow in a linear fashion, it's also true that the bone and other metastases are not as likely to be FDG avid as invasive ductal carcinoma. And this is a study that we did here demonstrating that these are less aggressive tumors and they're more likely sclerotic tumors, and therefore a negative FDG PET-CT in a patient with invasive lobular cancer may be a false negative. There are new tracers on the horizon, one of which is FES, and FES has recently become FDA approved, and it is a great tracer for estrogen receptor positive cancers. The E is estradiol. And for people with invasive lobular cancers, it's actually much better than, we think it's going to be much better than FDG PET alone. And here is a patient who has an abnormal MRI in a cervical vertebral body. Very difficult to biopsy that vertebral body, but when you do the FES, you can see that there is uptake in that vertebral body. And seeing that uptake in this patient who has an estrogen receptor positive tumor tells you that this is highly likely to be metastatic disease because there are not the same false positives and you don't have to biopsy the patient. Now, the last part of your question is how best to follow people with bone metastases. And that's, again, where I truly believe that bone scans are not helpful because if they get hotter, they could be healing, they could have a flare, or they could be getting worse. And so you really can't tell the difference. So either a PET scan or a PET MRI are really the better way of following these patients. And I'm not pushing PET MRI as much because it's harder to have access to them, and you can get a lot of information from FDG PET, and so that would be the way I would follow the patient.
Excellent. That last part was, I didn't even realize that was part of the question, but as you were talking, I was always wondering, and we always order PET CTs, well, not always, but it's so hard when I order bone scans and I have no idea exactly, is the patient healing? Are they having, I don't know if the bone tissue looks worse because
I actually have one more slide to show that this is not quite just about bone metastases, but recently the NCCN guidelines have changed. And it used to be very difficult to get PET-CT scans in all patients, even if they were highly likely to have metastases. It was that you had to first do a CT and bone scan, and then if they didn't answer the question, you'd have to then do a PET, which added cost, which added radiation to the patients, which made the patients come in multiple times. This is something that I personally worked on and went to the NCCN, as did others. And as of this month, you can see the guidelines have changed. You can now order the FDG PET-CT at the same time as a diagnostic CT scan. And if you do that, you don't need to do a bone scan or a sodium fluoride scan. So this is now much more possible. I highly suggest we start with women with 2B and higher breast cancer.